Thank you very much. So Dr. Achala Vagal is a tenured professor of radiology and vice chair of research of radiology at University of Cincinnati. She is we're so happy to have her as a multiple principal investigator or co-director for the UC CCTST. Dr. Vagal has extensive experience and expertise in stroke imaging and is actively involved in national and international multidisciplinary collaborations, including NIH Neurological Emergencies, Treatment Trials, NETT Network, Strategies to Innovate Emergency Care Clinical Trials Network, SIREN, and NIH Stroke Net. She's the contact PI of NIH NINDS R01 grant, a prize, studying population-based brain health for recurrent stroke, and NINDS NIA RFI grant, a prize, dementia, for post-stroke dementia. Excuse me. She is also the MPI of NIH StrokeNet U01 grant, Verify, which is the studying of TMS and MRI for upper extremity recovery. Dr. Vagal has extensive experience in leading image core labs for large multi-center stroke trials. As you can tell, she is an expert, and we are so excited to have her here today. Also, we have Dr. Bain Butcher. He has a co-appointment as an associate professor in both the College of Medicine, Department of Family Medicine, and College of DAP at the University of Cincinnati. He has teaching and research responsibilities in both colleges and works actively in the third space between art and medicine, facilitating arts-integrated research opportunities for students and faculty. Excuse me. Bain received his MFA in painting from the New York Academy of Art in 2006, where he studied with leading contemporary figurative painters. Prior to his time in New York, he received his MD from the University of Cincinnati and his BS from Davidson College. He completed his family medicine residency at UC in 1997. Recently, Bain was the co-founder and co-director of the UC Social Innovation Lab, and he has been the faculty lead on over 20 healthcare design research projects at the Live Well Collaborative. So we are excited to have them here today. And I will turn it over to Achala to introduce, oh, I'm sorry.
Oh, I was going to say, I have $1 million question. Are you seeing my presenter mode or my?
That's right. I'm seeing your presentation mode.
You're seeing my presentation mode? Okay.
Yes.
No,
so you are good to go.
Wait,
ready to go. No, it's full screen. It looks good.
Yes, it looks perfect. It looks perfect.
Okay, perfect. So hello all and welcome both from me and from Bain. One thing that we should just let you know, this is like going to be a tag team. Bain and I have worked together on the designs thinking project in radiology that I'll be showcasing. And we actually like each other. We would just say that, we have enjoyed working with each other. And so hopefully you'll get something out of this, will spark some, conversations. And we are going to have some time at the end to basically look to address some questions, but feel free to put it in the chat. We might not be manning the chat at this point as we give the presentation, but then we definitely want to have conversations at the end. I'll do a few slides, I'll give it to Bain, and then I'll come back with, that's how we have planned this. All right, so let's begin with the topic, which is human-centered design in radiology. But before I go there, these are some of my disclosures. Some of the work that we are going to showcase was supported by the ACR Innovation Fund, and here are some of my additional disclosures. So if you think about it, what is human-centered design? When I say the word design, what do you think about it? Look around you. Your phone, your laptop at which you're actually viewing this presentation is design. So design is everywhere, right? But when you think of human-centered design, there are few key tenets of it, and which are creative problem solving, empathy, which is a big one, storytelling. What kind of design do we want in stories? Rapid prototyping and testing, because we want to know if the design is going in the right direction, and then feasible holistic solutions. And very importantly, design means understanding rather than assuming. Tim Brown, who's the CEO of IDEO, actually has a very simple way of looking at this. He says essential solutions are very often simple. They are human-centered. Listen to your users. And I'll give you an example from radiology about the Adventure series. So this is a 6-year-old who is going to get into an MR scanner. As a radiologist, I'm thinking, do I get the perfect images of the brain? Do I have high signal to noise ratio? Do I get all the sequences? The technologist is thinking, has the protocol been set up properly? Guess what the frightened looking young patient is thinking? That's completely different than what we are thinking about. And so given this problem, and GE Healthcare actually worked on this, they created something which is called the Adventure series. They created these MR scanners into Submarine Adventure, Coral Adventure, Cozy Campus. And the whole point was you are creating this imaginative world in which the children could consider this as an adventure rather than getting frightened into a scanner. Now, this approach not only improved the overall compliance in terms of the patient not moving, which is very important, so lessen the sedation, but also improved the staff and family experience. So this is one example when we think of design. But if you think of human-centered design applications in healthcare, and this started with business world actually, but if you think about the healthcare, it is bridging gaps that occurs during the patient's healthcare journey. So it's not about just designing equipment and spaces, it can be designing or rather redesigning systems and operations. And why does it matter? Because anytime we tackle anything, the biggest question we have to answer is why, right? We have to start with why. And you and I know very well that the challenges of healthcare are centered at the human level and what we call as the wicked problems. They are complex problems. We've got to focus on the patient rather than the patient's condition. And consumer experience matters. I mean, we have, if not us, at least family members, friends have been patients, and that experience matters. And then very importantly, deeper engagement of all users. So you're designing with them and not for them. And then, of course, you have to have meaningful innovation as we look at this. So there are multiple schools of thought about design thinking and methodologies. One is the IDEO framework. So you start with inspiration. Okay, I have a design challenge. How do I get started? What do I do? What kind of interviews do I do? You've got a lot of ideas. Then you ideate. You have, what have I learned so far? And how do I turn those insights into tangible ideas? And then implement them into a solution. So you're diverging, converging, diverging, converging. Other one, a big school of thought is the Stanford D School. Same principles. You've got to understand with empathy, understand the audience, learn from the audience, create, define your point of view and the idea that you want to go forward, ideate, brainstorm, again, develop a prototype, test it quickly, and then go back to the original user. And you can see that, that these are not going to be linear. These are iterative processes. And we had a design thinking journey for a couple of years at the University of Cincinnati in the Department of Radiology that I will get into. But very importantly, we had very strong collaborators, which was UC DAP, the College of Design, LiveWell Collaborative, and the GE Global Design Team. And with that, I'm going to give it over to Bain, who will explain to us what exactly is LiveWell Collaborative and how that works. And then I'll come back and we will talk about the particular example in radiology. So I am going to stop sharing. And Bain, you can take over.
Okay, let me first share and make sure. Can everyone see that?
Yeah.
Does it look good? Okay, great. Well, again, I'll echo Achala's comments and welcome and thank you for this opportunity. And what I want to do is kind of zoom in now and discuss what LiveWell specifically is and how it facilitates this kind of design thinking research, in particular as it connects with healthcare projects. And then we'll go back to the specific project we worked on. But it'll make a lot more sense if we just kind of step out and understand what LiveWell is and how it functions. And so we'll go through that. LiveWell is over at the 1819 Innovation Hub, and it is a collaborative, a nonprofit that was founded in 2007 by University of Cincinnati and Procter & Gamble. And it functions in 16-week semesters using a design thinking process in collaboration with sponsors and researchers that bring projects to us. And it's a unique academic innovation center, and it leverages multidisciplinary teams of students, faculty, co-ops, and graduate students. Since we've been in existence, we've had over 1,000 students, 200 co-ops, 100 graduates, 50 plus faculty, 9 of the colleges at UC, and over 10 fellows. And LiveWell has its own particular approach to design research, very similar to the ones Achala outlined, but they develop their own process over the number of years, working with a variety of sponsors, and I'll go through that after this introduction. These are some of the partners that we've worked with. Much of what we do now has become specialized around healthcare research and healthcare projects. We do a lot of work with Children's and with UC Health and UC, along with some of the other sponsors that you see here. So basically, again, to echo what Achala talked about in her introduction, the idea of co-design. Co-design is really critical to the success of all of these things. And the idea is that there's a very large scale, again, a wicked type problem, a challenge that involves multiple stakeholders with very sticky, unclear solutions. And really what you're trying to do is create a possible future or an alternative future rather than a right or a wrong, but to try to take a certain circumstance and move it in a direction that is better for the whole ecosystem that's being looked at. And empathy, again, is central to this. The idea is to try to create empathy-oriented ecosystems for both patients and clinical teams. So you have to look at the entire thing. It is patient-centered, but it's also the whole ecosystem, because if the entire ecosystem functions better, then the outcomes actually improve. So we look at behavioral and cultural challenges, equitable access, wellness, and again, empathy is very, very central to this. So LiveWell brings to these projects multidisciplinary teams. They're faculty-led and advised, and they are comprised of co-ops and fellows and students across multiple disciplines. The teams are assembled in collaboration with project sponsors and principal investigators that bring projects to LiveWell. And the idea is that the team is assembled with the expertise needed to work on the project. And because it's multidisciplinary and because there are a range of approaches and thought processes involved, there's always a very fresh perspective, a lot of out-of-the-box thinking within these multidisciplinary teams. And at the end, the project sponsors or the PIs get implementable and effective outcomes that are decided upon early in the project and then co-created together through the 16-week design sprint. So again, the experience includes kind of design thinking processes. So the people coming to LiveWell actually get immersed in this process and learn how it works themselves, so they can take it back to their organization or their department and implement some of these things into the future on their own. Qualitative research, some of the tools that we use to drive our insights and to help with the challenges are also things that are translatable and can be taken back to the institutions and to the departments. And at the end of each project, there's much greater clarity about the scale of the challenges because of the interaction with end users and because of the ability to get this qualitative information from the entire system that's being studied. Some of the types of results that come out of our projects. This is just kind of an overview of the types of design solutions and deliverables that might be attributable to an individual project. So there's a lot of system and service design, looking at things like workflows, efficiencies, quality, patient experience, those kinds of things, but also a wide range. Some projects end up with patentable devices, possibly animation videos, some graphic design or spatial and interior design products, virtual reality, web-based design. The radiology project that you're going to hear more in detail about actually touches on several of these deliverables because it was a multi-semester project. So there are a number of these categories of deliverables that came out of that project. So we've had over 60 plus healthcare projects and over 20 plus grants at this point in time, both in collaboration with Children's Hospital and UC and UC Health. A few project highlights. We've worked with the Cancer and Blood Disease Institute, with the PICU, looking at situational awareness, sickle cell disease, palliative care, wide range of projects at Children's Hospital across multiple departments, including the administration. UC Health, obviously the radiology project we're going to highlight today, and you'll hear in detail about that. We also have worked with the Gardner Neuroscience Institute with Dr. Broderick, trying to optimize the stroke patient experience and journey, along with brain tumor. And then also with Dr. Barrett at the prostate cancer, or at the Barrett Center, looking at prostate cancer patient journey. Lots of recognition, lots of publications, and also lots of grants coming out of the collaboration between researchers and LiveWell. And so these are just some of the recent design awards, but we've also had a number of publications in collaboration with our PIs. And then I'll go through our process briefly before I hand it back over to Achala, so that you'll understand a little bit about how these projects flow. And this is just a diagram that is an overview of the process from the planning phase to the actual 16-week studio to the kind of handoff phase. And we did, for this radiology project, it was actually 3 linked 16-week projects. So we were able to actually go from a large scale of, scoping the project and then to drill down on some individual deliverables, which Achala will go into. Okay, so in the lead in, there's just a lot of conversation between the PIs that want to bring a project and LiveWell to discuss what kinds of deliverables, how LiveWell can actually help, either with a grant-funded project or with a specific patient experience or product-oriented project to help the researcher or the sponsor achieve their goals or address their challenges. And that can last for a few months, just preliminary conversations ahead of time, including a design workshop. I think the radiology department did those workshops before the projects actually started. So then in the research phase, our teams began to benchmark, look at literature, start doing interviews, direct observation of things like workflow, patient experience, depending on, again, what the project is about, lots of surveys. And the idea is for the team to gain a functional literacy about the challenges and problems of the actual project itself. And then during ideation, the team meets again with the researcher and the sponsor to work together to start brainstorming ideas for solutions. So there's co-creation sessions, there's a lot of visualization, a lot of storytelling. Sometimes we use personas, where we generate representative personas that help us walk through scenarios and test the challenges conceptually, which we can then take and test it, sort of in the real world to begin collecting data. Wireframing, and then the rapid prototyping, again, that Achala referred to. We start actually making small versions of things, whether they're system maps, journey maps, products, and start testing things to see what might be a better direction. This whole early research and ideation phase is sort of called the fuzzy front end, meaning that you're sort of roaming in the wilderness for a while until you start to get focused. But the idea is that you want to get as much breadth as you possibly can early in the project, so that you're not leaving stakeholders out. You're thinking out of the box as long as you possibly can before you start drilling down on the specifics of a solution. And then refinement grows out of the ideation phase. And the idea is that once several directions are sort of co-designed with the researchers and our team, then we start making decisions about specific directions and then start refining prototypes. And at that point, you can do continued user testing to make sure that the refinements and the choices you're making make sense based on the assumptions you made earlier in the project, and then start building the physical prototypes, either of the system maps or the products or whatever the outcome is, the deliverable that you were hoping to have. And then start talking about a strategy for handing the project off and testing it, because ultimately the project goes back to the original researcher or the original sponsor. And from that point on, after the 16 weeks, it's up to that original principal investigator to carry on the project into the future. And then that's what the handoff essentially is: confirm that all the deliverables are completed and that there's a strategy moving ahead for implementation, and potentially metrics for testing the efficacy of the intervention or the product or whatever the deliverable ended up being. So the last thing I'll just mention is, again, it's an iterative process. Some people bring projects that are a single semester, and in a single semester you can get insights, initial prototypes, and you gain a much deeper understanding with some qualitative reflection and data about the challenge. 2 to 3 semesters, essentially you get much more refined prototypes, much more specific outcomes that can then be tested with specific metrics. And I'll just end by saying that we're always open for anyone that wants to come and visit and learn more about how LiveWell operates, or whether LiveWell could be a good fit for projects that anyone wants to bring. And I'm happy to answer questions about that later in the presentation, and I'll give it back to Achala to tell you more about the specific radiology project.
All right, so let me share my screen and let's go. All right, first thing is, what are you seeing? Presenter mode. Okay,
Looks good. Yep.
All right, perfect. Okay, so let's start back off now that you have a little background of what the LiveWell does and what's the process. Let's go back to our design thinking over here in the Department of Radiology. And so same thing, we used this kind of a design thinking process, and non-linear but multiple iterative processes as we went through the whole journey. So our big goal was, when we started, was to understand the optimal patient experience. Now that's a very wide, and that's a very, it's like an audacious goal too, because first, if you want an optimal outpatient experience, you have to first understand it. And what we did in the very beginning was this 2-day retreat where we got everybody together and we just brainstormed ideas. Where do we want to go? What do we really need to know? And what we realized is, to be able to understand an outpatient experience in the radiology department. And for anybody, was never ever visited a radiology outpatient department, it's anytime you need a CT scan and MRI, because we want you to focus on those two. Otherwise, you can have X-rays and ultrasound and nuclear medicine. The range is wide, but we wanted to say, okay, if you go to an outpatient, what is the experience? First thing we did was research, stakeholder interviews, which was stakeholders, when I say in the radiology, is not only just the patients and their journey maps, but also technologists. And then also trying to understand, okay, who are the influencers of positive and negative experiences? Then what are we learning from these insights? And can we build some functional prototype solutions? And we cannot do everything. So maybe let's go create the top 10 areas of opportunity, then test those concepts, present this ideal journey, and then create a project pipeline. So like Bain mentioned, this was a long process. It was over 3 semesters. So we started from, again, understanding. And so here is one of an ideation workshop in action. And remember when I said multiple stakeholders, which means patients, patient family, PFAC groups, technologists who are our frontline, for the radiology, the radiologist, trainees, managers, schedulers, registration desk, every touch point as they come in, the patient comes in, and then this is a workshop. You can see a lot of interaction over here, a lot of people trying to put on, in these, whether it's sticky notes or colorful notes, what are the challenges and how do you identify the feature of a challenge? One personal thing that I have learned in this kind of journey is yes and versus no but. And I hope I hope I'll never forget that kind of lesson, even in a simple meeting. When somebody says, "Oh, we should do that," the first reaction, at least, sometimes like, "No, but we cannot," versus design thinking says, "Yes, and it might require X, Y, Z." I think it's a kinder way of addressing some of these things, but it's also like, yeah, tell me your ideas. No idea is off limit. And that's exactly what we encouraged in some of these ideation workshops. And the other thing that you heard, Bain, was co-creation, right? Again, all stakeholders coming together, coming as a team. So it was a very team enabling process, and we had a lot of fun during these sessions. There was also widespread support of people, coming together. We had almost 27 clinician participants, again, radiologists and referring clinicians. In radiology, I would say our two, biggest customers, if you may, are the patients, but also the referring clinicians who send the patients to us with their orders. We had technologists, almost 12 technologists, 12 patients, administrators, and also the leadership, including UC Health CEOs. And 3 focus areas basically emerged in these, because once we did this, but before I go there, we also took the opportunity after the team had come together to basically show our ideas, our vision to the bigger department, right? And you can see over here a packed house, and oh, by the way, I should tell you, this was pre-COVID. If you're wondering, I wonder if radiology ever has heard of masks. This was pre-COVID era. And so so again, we showed it to everybody. We discussed where we want to go, because again, you cannot have a design, and we are talking of designing systems here, without everybody on board. So once we did that, trying to understand how do you optimize an outpatient, basically, we had multiple project pipelines, and I will not go over here, but you can imagine every touch point, you can do something better in healthcare. But we figured that, okay, the 3 top things that we want to focus on was humanizing radiology, transform the brand and culture, and information sharing. And when I say humanizing radiology, I'll come to that. But one of the biggest things is people don't know who a radiologist is. People don't know, they would ask the technologist, be like, are you going to read the report? And are you, when I'm going to get the report? And so also, do you understand I have to go to another, appointment after that? And how are you going to tackle that? So just simple things like this, I think humanizing is always a good thing. And it came out in many scenarios. And one scenario that I can tell you, particularly which stood out for us, was education. And I'm going to go specifically into this case study, because I don't want to tell you what, like all these big opportunity, project opportunities. And so we did 3 main ones. One was because education stood out, patient education and humanizing radiology. We actually had a pamphlet and videos. We created schedulers. We wanted better scheduling tools, and then some interactive reports. But I'm going to focus on one of them, which is this pamphlet development process. And before we get into that, one of the biggest things which struck to me in our conversation in those qualitative interviews, we collected a lot of data, right? As Bain was saying, a lot of interviews and, stakeholder interviews and understanding it. But some of the data is not always captured as how many patients came in, what was the, next appointment available. Here is a scenario. A young mother comes for an MRI appointment, And usually an MRI can take anywhere from 30 to 45 minutes. And a young mother comes in with her toddler because somehow she was never told, or we didn't do a good job about educating that, by the way, you go into the MR scanner alone. Now, guess who is managing the toddler and babysitting the toddler? The technologists. And now can you understand the frustration of the technologists? Because our technologists are like super duper smart, and they work in a very kind of, a difficult environment with multiple demands. And now you have to manage a crying toddler who is worried, why am I not with my mother? The mother is anxious. Why is my toddler? She is moving. It's a simple thing. You can understand the frustration. And that's what I really like about the human-centered. I will go one step beyond that. We are all patient-centered, and we want to do the right thing for the patient. But I think it's beyond that. It's got to be human-centered. When you are creating processes and we say, oh, everything is all about the patient, and we forget the rest of the human elements, I don't think we do a good job. So in our case, an unhappy technologist absolutely translates into an unhappy patient. And so this human-centered process is like so critical. Again, this is the number 2 lesson I've learned. It's not just about the patient, it's about human-centered. So if you look at this pamphlet development, the reason I'm saying is, okay, if you have to educate, like, what do you expect when you go to a radiology department to get your MRI or CT? And you can have multiple processes, right? And I'm going to go through some of these things which Bain has already talked about, because we realized that people didn't have the information. So the number 1 thing is information research, right? What happens? It starts with referral. A patient gets like, you need a CT scan or you need an MRI. So it starts with the referral, then they arrive, then there is a check-in, then they get their imaging, then they leave radiology, and then they get the report. And of course, then they get the bill. We did not touch the billing process. So that's a whole different beast, and we did not go there. But let me tell you what we did when it came to the development of this educational material. So this is a visual, so we put in these sticky notes, like the teams that I showed you, put in the sticky notes and said, okay, here are the stakeholders. Okay, if I see referral, arrival, check-in, imaging, here are my stakeholders. What activity happens? What are the current existing tools? What are the expectation and what are the opportunities? So this map or this information integration is really, really critical, because there are so many pieces, and many times the registration desk person doesn't know what's happening when the patient is in the scanner. So there are, again, multiple touch points. Then we created something more, again, in this integration, understanding what is this patient journey. And you don't really need to look at, because this is so specific for radiology, but I'm just showing you a showcase of how the check-in, multiple processes that happened, we had to go through each one of them. Then we also did visual benchmarking. What can we showcase in a better way? What are other people doing it? So the team helped us think about, what are the visually benchmarking, what can we do? In the benchmarking, we also found that there are different illustration styles. Remember, I said people don't know who radiologists are. And I bet, some of you, if you go back home and ask, like, what does a radiologist do? The first question will be, are they doctors? I don't know. It starts from there. So we wanted to showcase our radiologists, and we went through these iterations. The first one, we thought, too childish. It doesn't match what we want to, our brand. The second one, we thought it's less childish, but it's too clinical. And then we settled on this draft number 3, approaching, comforting, not childish, and it kind of matches our brand. So these are some of the things that we work with the design team. And we created this journey, right? So the patient comes in, or before even they come in, they get a referral. Then when they are leaving home, what happens? Do they get the transportation? Can they find the parking space? Then when they come to the registrar, and then what happens during the scan, and then of course when they leave radiology. And one of the things that, big thing that we realized is that patients get lost. Now, I'm speaking to the choir over here. And of course, this is already kind of, outdated because it's no more a Goodwin garage, but patients get lost because to come to the main hospital, there are just so many ways. And that was one of the frustration points. So in the pamphlet, as we were creating, we had to create these pictures of where you can park and how you can come. And we realized that, we need to have a pre-scan. What do you need to do? What do you need to bring? Again, an MRI, checking for metal is a big one, right? And it's important for patients to know if they have a tattoo, or if they have some kind of a removable, earring or something. It's better to do that and understand that before you come to the scanner and then get frustrated. So pre-scan. Then what happens during the scan in the radiology departments, and post-scan. So we build these journey for a patient to understand. And I can tell you that we had these multiple iterations. This comes back to the prototyping. Multiple iterations of this. We went back to the care team. We also learned that you cannot build any product without following our marketing branding guidelines. So we had to go make sure that we involve the marketing team. And then when we went back, we said, okay, we went back to the care team and the patients. What do you think? Well, the pamphlet is simple, it's understandable. And then some of the feedback that we got from this going back, remember I said the prototype has to be tested, but it has to be fast and it is iterative. So we went back to the design table and we said, okay, we have to redesign a few things because I think that makes more sense. And then that's how we came up to the final, if you may, pamphlet about what happens and what's your care team. This is the day of the scan. This is pre-scan and this is after scan. We also had a QR code. And one of the things that we realized is patients are different, right? So some patients they'll be like, I don't need a pamphlet and I just give me a QR code or send this information in my electronically. But some patients may not have that kind of, access to all the gadgets, and they wanted something, specifically in their hands. So we had to kind of understand our users before we started making this. We also made videos on this. And we are still in the dissemination phase. We started with it, and I can tell you COVID coming just changed everything and how we are going to do this. So we started the dissemination, and then we started doing more of the QR codes and electronically, giving out this content to the referring physicians and when the patient gets their appointments. I'm now going to take a little time to say basically we had some challenges and I wish I could tell you, oh my God, this was perfect and we did it and UC Radiology knows how to do it. I'll be very honest with you. This is time and effort intensive. You need champions at all levels because this, again, we are talking, yes, we created a product, if you may, a pamphlet or information brochure or a video, but it is also dissemination, right? So you have to think about the culture, shifting the culture, and it is design doing versus design thinking, because once you have it, you have to actually do the work. The other big challenge, I think it's really hard to measure success and outcomes. So we did this and, the Press Gaining scores, and of course, all of us want, the patient experience as one part of it. Our Press Gaining scores actually really, really improved, but we also were doing multiple other things with it. Some of the, other initiatives that our technologists have been taking. And so we cannot tease out and say, oh, this improved, the patient experience. So I think it's hard to capture, particularly when you are doing systems and processes. But I also want to take a few minutes to say that COVID-19 was actually the ultimate design thinking platform. So if you think about it, the masks were designed, right? Because the users wanted it a certain way. And then we designed our messaging. Sometimes it was good, sometimes it was not. And we designed how we are going to stand in the grocery stores. In the healthcare, in the department, we designed how we are going to create the space. So we are creating now, and we all were doing this in your own departments. I bet you were doing it. So we were designing our reading rooms. How do we separate the radiologists? How do we clean it? What is our system? Digital learning. So we have all been designers thanks to COVID-19. And so my final takeaway is that human-centered design, again, they can be simple because if you listen to your user, and empathy and understanding the user is very critical, and the co-creation. And I think the time is ripe where we can redesigning the healthcare experiences should be on the top priority for all of us. And I hope that I leave you with the creative confidence that we are all designers. And I think we have a lot of potential amongst all of us to do this kind of work. And I will stop over there, and I'm going to unshare my screen so that we can take questions.
Awesome.
I just want to add one quick thing before we do questions, to just reiterate the kind of the power of actually focusing on asking the hard questions of the end users. Because, I mean, how many times have we all had experiences where, we're having a negative experience, whether it's with a website or at a doctor's office or wherever in life, or the whole COVID experience, did someone ask you what would be a better solution? Well, the idea behind this is that, these projects rigorously ask that, and actually look for challenges. So instead of avoiding the negative feedback, it's embraced, right? So that by the time you get to a pamphlet, you find out that, hey, they love the radiologist, but maybe the parking is terrible, or there's some other issue. And so until you ask those questions, you might not really know what the relevant issues are. And I think to your point, Achala, about COVID, one of the things about that is that because it was a pandemic and because people's lives were at stake, people had the courage to just solve problems and rapidly prototype and be creative. And there wasn't time to wait till someone told you, yes, it's okay to move that chair over there or whatever. It was kind of all hands on deck. So everyone was co-creating in their own local levels. And I think that really does point to the power of everyone being involved, everyone being empowered to work towards solutions. And I think there was that was embraced more, right, because of the situation. So I think that's just a really great example of how the whole world really experienced that kind of co-design. So.
Yeah, no, I agree. Well said.
Thank you both. This was an excellent presentation. Appreciate that we have time for questions as well. And since we have a smaller group, I would just encourage either unmuting yourself or raising your hand for questions at this point. Or comments. We have a nice comment in the chat from Bruce. So Bruce, if you'd like to unmute yourself to say that yourself, or I'm happy to do that. I'm sure both Achala and Bain can see it as well.
Hi, everyone. This is Chris Richards from School of Medicine. Very interesting. Bain, you kind of commented on this a little bit, but I'd be kind of interested in hearing a little bit more about just like the logistics of the program. Like, if I had an idea, would I come to you just with like brainstorming? Do I have to kind of have a little bit of a baked idea? Do I have to have funding? And then is it kind of a rolling thing anytime during the year, or is there a time of year specifically that you're looking for starting these projects?
So LiveWell works with investigators, clinicians, sponsors on a semester basis. So it's lined up with the academic semester. So fall, spring, summer, and generally projects are a semester or two out. So in other words, if someone's interested, say, in working for a summer project, they would be talking to us now, kind of reaching out and having discussions about, hey, is this a good fit for LiveWell? And yes, the investigators generally bring their own funding. LiveWell is a nonprofit organization. So the money essentially goes toward assembling the team of the faculty and the students and co-ops. And so that's how that piece works. And depending on the scope and scale, we have those conversations about, is one semester enough? Do you need to consider a longer term project or help refine what you hope to get out of? I think projects are most successful when the sponsor and investigator has a clear idea of how they want to use this kind of creative problem solving and human-centered design to expand something they're already trying to achieve, but maybe aren't able to just with the resources available to them. And so we do help people sometimes clarify and focus their ideas for how to work with us, but some projects also just aren't necessarily a good fit. So it's a matter of starting a conversation and deciding if LiveWell can be of assistance. And LiveWell is a great resource for researchers, clinicians, and administrators. We just have to have good conversations about, how to use the capabilities to further. And actually, I will say both at I would say at Children's, certainly there is the scalability piece. So sometimes people will bring a project and metaphorically it has ramifications, implications across maybe multiple departments. And so then there can be some additional assistance to kind of help scale an idea that looks like it might be applicable to a broader group. And I think that gets to Achala's point of the challenges and difficulties of kind of re-educating sort of cultures to understand that these things actually in the end improve efficiency, improve work culture, and ultimately economic efficiency as well. So, but yeah, so it's just a matter of reaching out to LiveWell and, by email or, to me, I can connect you with our executive director, Linda Dunseith, and just kind of have conversations about how to move forward, or even just come for a visit. So that might be the easiest thing, just to understand a little bit more in depth how things work.
Yeah, and I will say it is a pretty cool space, to visit in that 1819 building.
It sure is. Linda, did you want to put your contact information or LiveWell's contact information in the chat? That would be helpful, I think, too.
I will certainly try to do that. I'm actually remote right now.
Oh, okay. It's okay.
But please do. We do have a website, livewellcollaborative.org, which has a lot of case studies on it and just different examples of our work, how we do work, what our process is, and contact information is on our website. Thank you.
I just put that in, no problem. I'm sorry, I didn't realize you were remote. There we go. So it's in the chat.
And I would also add, just to build on that the project that radiology did with us, I would say is a really fantastic example of an almost ideal LiveWell project. And, the team was amazing that came from radiology, and they were so engaged and excited and had such great ideas and brainstormed internally, when we weren't meeting, and really worked to clarify the focus of the project. And as a result, they did 3 semesters. They had a large scoping project where they learned a lot about their own department and then moved forward with very specific ideas about how to improve certain aspects. And, the insights that are gained from that spill over into all kinds of other areas you learn a lot about just how your department or your organization functions. And then out of that, there was a grant that was received, as well as publications. I mean, it really is almost a model project for a longer term, multiple semester project. I don't know, Achala, if you want to comment more on that. I think it really...
Absolutely. And we had quite a few people who were, trained, if you may, in design thinking, because, some of our managers, and I think now if we have a project, we at least are thinking through that lens of like, have I talked to the user and, do I get the stakeholders? But yeah, I mean, we actually have published about this in multiple avenues. We have also given talks Our chair, Dr. Mahoney, has actually talked about this with her radiology chair group. And we have presented in one of our radiology, big conferences. We had like this, almost like a TEDx talks, but for 5 minutes, it's called Fast 5, which is the RSNA, which is our big meeting. And to be very honest, the world's largest meeting, 50,000 people come in Chicago, in McCormick, and this was showcased. And again, it is just innovative about thinking about, systems change. And again, I want to be very honest with people, and I think we have a long way to go, but we have at least made, the first inroads, if you may, into this process.
The follow-up's the hardest.
Yeah,
like carrying it forward after the projects are over.
Michelle, go ahead.
Yes. Hi. I work in oncology actually, and I worked on the prostate project with Linda and Bain and several other projects. But I want to say, I think partnering with key departments could really be helpful. So it's almost like you don't have to do it on your own. And I have to say, Linda actually gave me the pamphlet, and we have copies in oncology now. It's just, again, on the implementation that physicians know the importance of giving them out. So I think there's a pathway forward. I really do. And just finding key partners.
Yeah, no, I think very well said, Michelle. And one of the other things, as a health system, I mean, we even talked about, you need all the players on board, right? I mean, it could be as simple as, well, EMR needs to put this QR code, and then there were challenges. Well, we don't do that. But as a patient, you would think, why can't my UC Health appointment come with this QR code that I just click on it? But then there are certain systems in place which may or may not be, ready for this kind of progressive, different out-of-box thinking. But you're right, Michelle. I think you need the key players, but I would also say you need the top leadership to believe in it. And we were lucky that they were on board on it. But again, to take it forward, you need that momentum. So thank you, Michelle.
Right. The vertical alignment is a phrase that gets used a lot for this. You really have to have a champion at every level, especially for the handoff and the implementation part. For the project itself, those go very well. It's the after, does the organization then embrace what was learned in the project and facilitate the researcher or clinician or administrator who brought the project in order to carry it forward and scale it and actually help it to continue to grow? That's, I totally agree. There needs to be kind of institutional things in place that help to perpetuate the learnings and insights and gains that are made in these projects.
And did you want to go ahead and talk about what you put in the chat? I see you unmuted.
Yes, no, sure. I love this approach. This is an approach that we are using actually in the context of the work we are doing in neuro as well, journey mapping and all of that. So we've been trying to incorporate that. I think the power lies in using this approach at the beginning to kind of build your portfolio of work of what you want to improve on and engaging patients and families. But I agree that then when it's time to implement, you need that kind of quality improvement approach and methodology. That's what really can help you reliably incorporate all of those great ideas, like those brochures or whatever you end up producing, kind of incorporating those in the clinic flow in a reliable fashion, and then you can measure the impact over time. So I think design thinking, human-centered design associated with quality improvement, I think is the winning ticket if you can combine both.
Yes, I agree. And I think, and Anne and I met for the CCTST site visit yesterday, and we were like, oh my God, we need to connect because we have got so many commonalities. So we're going to chat a little bit more. But just to add to that, I think also, Anne, we, even when looking at it, sometimes those agile framework, right? I mean, once you do it, then, then you go into like you said, it's performance improvement, so I think it almost goes hand in hand with some of that. And that's why I said it's not just design thinking, it's actually design doing. At the end of it, you have to do it. So I think that's where sometimes there can be challenges.
Yeah, exactly.
And I would add to that we do see that in a lot of our sponsors who bring multiple projects over time, and we have a number of those organizations that work with us kind of continuously. They build over time very specific ways to implement the learnings, but in the quality types of programs they have. And to bring up the issue of testing, like you mentioned, the Press Ganey, what you have to have, and we've been encouraging a lot of our projects in the last few years. We've really encouraged the sponsors and researchers when they first do the project to start already thinking about the metrics that they want to use to track the outcomes, not just think about the project, but how they're going to measure it. And we sort of help them integrate that during the project, and then ideally work with the organization that they go back to help them sustain that and integrate it into some kind of system that already exists there. And I think that really is how this continues to improve, so that you're not measuring the outcome with a tool that doesn't pick up, having the wrong tool, basically.
Excellent. Any other last questions before we end? Or comments? This has been a great discussion. Thank you, Achala. Thank you, Bain. And thank you, Linda, even being remote. Okay. Well, we're 1 minute before 1 o'clock, and I know everyone's probably wanting to move to their next meeting. I just want to thank Doctors Vagal and Butcher again, to thank you again for your time for our last grand rounds of 2022. Can you believe it? Amazing. We got through the pandemic and continuing to move forward. So thank you again. We really appreciate your work and spending your time today coming from the site visit. So appreciate you coming and doing this presentation. It was excellent. I learned a lot. It sounds like everyone else has too, and we're finding commonalities throughout the systems and working together.